It's about 20 years since we had the meeting in the charity, thank you very much, a charity about evidence-based medicine. And how many people were here at the meeting of evidence-based medicine? One, that's small. Yeah, okay. And when we started evidence-based medicine, we also thought it would be evidence and value-based medicine. But we thought one change at a time was enough, so we focused on evidence, distinguishing evidence from experience from evidence from research. But in our original definition of evidence-based medicine, we said it was related to the patient preferences. And then we turned it into evidence-based healthcare, looking at evidence for populations. And that's been my main interest, is on the population side as well as the individual side. But we're now facing in every society a significant increase in resources if we carry on doing what we're doing. And our estimate is that in the next decade there will be a 20% increase in need and demand. That may be very conservative, 20%, might be more. And at the moment we're like the boy in the dike or the King Canute telling the tide to go back. So it is helpful to look back, and we've had two revolutions in healthcare. The first revolution was the public health revolution. It gave us Berlin's water. And of course that was political. It wasn't really scientific, it was political. It was empirical, not scientific. John Snow didn't know anything about bacteria. It was just about getting the water clean. And then Virchow, as you know better than I, played a leading part in that. But for the last 50 years we've had this fantastic revolution here, the high-tech revolution, that the medical profession has played a leading part in. So the application of science in the prevention, the treatment of disease, and in research methods. This is part of the revolution here. But at the end of 20 years of evidence-based medicine, 20 years of quality improvement, every society on earth faces three big problems. And the first is unwarranted variation, defined by Jack Venberg as variation that cannot be explained by variation in need or preference. And here's one of the maps from our Atlas of Variation. This is the percentage of people dying at home, from 45% to 75%. No evidence why it's occurring in different places. And I know there's been good work funded by Bertelsmann in variation in Germany. And we find variation in everything. This is PET scanning. This is spend in mental health, spend in circulation by population, population-based. So we've made the move now from quality to value. The quality is measured by outcomes and the patient seen, but value relates always to the population. More complex when insurance companies are involved, multiple insurance companies, but still very possible. And in Germany too, these are examples of cardiac procedures, knee replacement rates. This is international, unwanted variation. Now, the unwanted variation reveals two other problems, and the first problem is overuse of healthcare. And the Choosing Wisely campaign has made a major contribution to this, of course. So this is the most important picture image in medicine. Wittgenstein said every idea is a picture. And this is the key picture in the future of medicine. How many of you have seen, this is Avedis Donabedi in 1980. How many of you have seen this picture? Yeah. It's, so as you put more money into healthcare, the benefits increase, but then they flatten off. So once in a lifetime cervical smear, 10-year interval, 5-year interval, 3-year interval, 1-year interval. One intensive care bed per million population, 10, 20, 30. The trouble with healthcare is that harm goes up in a straight line. The more healthcare we do, the more harm we do. Now, quality influences the relationship between these two lines, but the two lines are always there. And what I'd like to do, and I do this if I'm in a town hall with the public there or in a group of doctors and patients, I ask them to turn to their neighbour and identify what sort of services are we talking about where we think we've gone beyond the point of optimality. So just to warm you up for the morning, turn to your neighbour and tell me give me examples of services where we've gone beyond the point of optimality. Okay, just spend 2 minutes with your neighbour now. Introduce yourself if you don't know it. Where have we gone beyond the point of optimality? Okay, let me just, in the interest of time, show you. I've done this maybe 100 times. And let me just show you what comes up in England and in Italy. Here's the sort of things that the audience bring up. Public as well. Antibiotics, obviously. But chemotherapy in the last week of life. See, we're not saying that no one should have chemotherapy in the last week in life, but did they really know what the choice was? Imaging and lab testing. I don't know what's happening in Germany, but imaging is going up 12% a year in England. Lab testing, 6%. So what was the value of the last 10% of the increase? Polypharmacy in people with frailty. People dying in, older people with frailty dying in hospital. Again, saying, we're not saying that no older person with frailty should be admitted to hospital and intensive care. And we're not saying it's about the money. This is not about the money. This is the line I would be taking if I was in the town hall. Or it's not about the money. It's about the balance of good to harm. And this, again, we're choosing wisely, has been so helpful. Intensive screening and elective surgery, for example, cataract and knee. Any groups come up with other suggestions? Yes?
I think in Germany it's also the hip replacement.
Hip replacement, yes. Yes, almost all elective surgery now is being looked at, yes? Catheterization, yes, yep. Stenting, and I speak as someone with a stent, but my stent was an acute episode, yeah. Others? University administration. Yes, but we'll come back. That's about productivity, but certainly the same Tainter's book in the complex of almost all of administration. We've now got revalidation, which takes, it was introduced because of the mass murderer, but now there's been no mass murder since it was introduced. But it's the time that's taken. So almost always we get over complex. Anything else? There are, almost everything you look at, we look at different bits of prescribing. So, other things come up would be a number of intensive care beds for children. Has that created pressures? And this is from pediatricians starting to think about the changing nature of appointing the pediatrician who's also a chief exec at the back there. Okay, so now the other problem is the problem of underuse. So in England, we would have 5,000 fewer strokes and 10% less vascular dementia if everyone did what they do in Bradford. Bradford's a big, tough place and the equivalent of the Ruhr. So they don't have any more money, they have no more technology, they just get organised. And then there's this problem of inequity. And in the NHS, poor people get less hip and knee replacement than wealthy people, which has led us on to develop. This is a bit complex technical language. Triple whammy healthcare. Triple whammy healthcare, where there's overuse. This is a wonderful editorial by the professor of orthopedics in Oxford. Arthroscopic surgery for degenerative knee. Overused, ineffective, and harmful. We have a 50-fold variation in arthroscopic surgery of the knee, and there's underuse of knee replacement in poor people. Triple whammy healthcare. Variation, overuse, and underuse. Okay, so what are we going to do about it? Well, we've all done 4 things in the last 20 years, and these need to continue. And the 4 things have been prevention, evidence-based decision-making, quality and safety improvement, and productivity, cost reduction. So we need to move, but while we've been doing these things, these problems of overuse, underuse, and variation have evolved. So we now need to move to a different way of thinking. These need to continue. These are essential. But we now need to move on to value. And we've defined value in the program, and we use the phrase triple value. And And there's also waste. Waste is the inverse of value. It's not just what we put in the waste bin. It's anything that does not add value. This is very Toyota. Muda. You know, Kaizen is continuous quality improvement, and Muda is waste. I learned another Japanese word from a Japanese student who was with us. It's motainai. It's a feeling of remorse for having wasted resources. Oh, no, 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 no. I don't see much motainai in the NHS, I can tell you. But, so, waste. Now, let's just get the language right here. I'm doing this. I still haven't got even the top of our office to use the language consistently. So productivity. This is English, and you know, I'm a Gastarbeiter in England, so I've had to learn Southern English. So productivity is outputs over inputs. Number of operations per operating theatre, number of admissions per bed, mean duration of stay. Efficiency is outcomes over resources. And we also, so resources are not only that, but they're also carbon. All our hospitals have carbon budgets. And we find that the frontline staff are often motivated more by carbon than by money. You know, if you say we'd like to reduce the carbon footprint of this hospital, staff come up with lots of ideas. Now, reducing the carbon footprint almost always, that 20% of the carbon footprint is heating and lighting, 20% is staff and patient travel, and 60% is the carbon and drugs and equipment. So by going for carbon, you're also getting people to think about then time. We've really ignored the time of patients and carers. But if you've got a 94-year-old mother with Alzheimer's disease, and we'll give you a 9 o'clock appointment. I mean, the logistics for the family are just huge. So we're now starting to involve the use of time. So, and then value is bigger than efficiency. Its technical value is greater than efficiency, because we have to think of overuse and underuse. And then the triple value. So that's just the jargon, and it's all in the note. And Gunther and I are preparing a little glossary of these terms. Now, here are the 5 new things. I'll just go through quickly. So we have to carry on doing the 4, but these are the 5 new things. Number 1 is ensuring, this is personal value. And this was the model we used for evidence-based medicine. So the evidence is derived from the study of groups of patients, but that evidence has to be related to the individual, by the clinician, and then we've got to take into account the value that this patient places on the benefits and harms of the options, and the value they place, the preferences they have, and the values they place on risk-taking. So this has been the standard approach. Now, population medicine and population value and personalized value are 2 sides of one coin. You see, if you take something like cataract, and the vice president's an ophthalmologist, when we started doing cataract, we only operated in people who were really, really housebound, and the benefit was fantastic, but there is a risk in the best of hands. As you do more interventions, it's the same from a population, remember the curve, the Donabadian, but as you do more interventions, the choice offer the individual changes, because you're treating people who are less severely affected. So I use the economist's high, low, zero value. In clinical language, necessary, appropriate, inappropriate, and futile. And you may reach a point where it's futile. And this is often a discussion between anaesthetists and surgeons about should we operate someone who's got a leaking thoracic aorta. Well, the anaesthetist says, yeah, I'll get them off the table all right, but they're going to have 10 days in intensive care and then die in intensive care. Futility. There's an increasing debate about futility in the medical journals. Now, this is starting to bring up issues very relevant to the Berliner Ärztekammer and all the other Ärztekammer in Germany, because we're now in the 3rd healthcare revolution, and it's driven by 3 forces: citizens, knowledge, and this. This is more disruptive than the human genome. And it changes the relationship between the doctors and patients. And we're now thinking a lot, and I've done all this evidence-based medicine. That means I've made doctors spend more time worrying about evidence and looking at computer screens and less time looking at the individual. And our payment system for doctors means they spend more time recording stuff. And Mr. Gates said the key question is, what is the function of the human being in the digital age? And it may not be to give people information. With Gigarints, or we can give information this way, to think about before you come. It may be that the key contribution is empathy, is caring for the individual and helping them reflect. But is that what we're training young people for? Or is that what the system is for? So this brings up big issues. So we're starting to look at ways, and I know some people in Germany are doing this ahead of us, but how could we, before you come to see the doctor, then could you please write down what is really bothering you most? And what do you hope we can do to help you? It may be the diagnosis will solve that problem, but it may not. So start thinking quite different ways about, in many ways, old-fashioned ways, like so the doctor's the healer. So we've had the doctor as the healer, the pictures, then the doctor as the scientist, then the doctor as the manager, but now we're getting to see the doctors as the creator of value. And for value for the individual, it may be empathy is even more important than the application of evidence as the contribution of the human being. 2, now this is allocation of resources. And I saw as I walked down Wilhelmstrasse, so how much money goes into healthcare? That's the first sort of level of allocation, number 37. And for us, it's perhaps more explicit than in the insurance-based world about what percentage of the GNP and what percentage of public spending. But when we then get down, and this is for us quite easy because we have a tax-based system, but start to look at what we do is if we spend resources, so it's gastrointestinal is about 80 million per million population, pounds. Respiratory 100 million, cancer 120, mental health about mental health 11 billion pounds, 11% of the budget, probably about similar here. People always underestimate how much we spend on mental health. What we spend it on is very unclear, but it's the GPs say, oh, lots of people have more than one condition, as indeed they do. So we call this complexity. And the complexity is a 85-year-old woman with 5 diagnoses and 12 prescriptions, looked after by a 50-year-old daughter with an alcoholic husband. Standard general practice, standard family medicine. But when one of those goes wrong, they need to get the specialist involved. And we've sort of separated generalists and specialists quite badly in the UK. I think with the Ärztekammer you haven't got that separation so bad here, but it is an issue of respect between specialists and generalists. But what we're wanting now is for the doctors to take responsibility for the next stage of allocation. Because if you look at the variation in activity, that reflects a variation in allocation of resources. So you go to one part of England and you see it's a terrific glaucoma service, and then you go 20 miles and there's a wonderful AMD service, but not a very good glaucoma service, because in the first place, I'm pointing at the ophthalmologist here, in the first place there was a very keen glaucoma person for 10 years, and the next place was a very keen AMD specialist. Just, it's sort of grown up over time. But we now need to ask the people, have we got the balance right? You want more money for sleep apnea? Well, where's the money going to come from? So get the asthma people and the COPD people and the sleep apnea people in a room, and we'll lock the door. It's too technical, and it's also too variable to make a decision at national level about this, because the pattern of spend is quite different. I'm sure it'll be the same here. It's a little bit more complex here with insurance companies, but it's tying it all back to populations. Now, number 3, are we seeing the right patients? And because broken legs, you see, worked pretty well. If I get run down out there by a car, I'll get to the right hospital. I don't know which hospital. Which hospital would I get to if I was run down out there? Which hospital would I go to? Your hospital? No, too far away. Okay. But someone would know, wouldn't they? So I'd get to the right place. But most of healthcare is much more complex than broken legs. And the relationship between the people who see the specialists and those who would benefit most is pretty poor. Now, what we're doing with this is starting to think a lot about the role of the specialist as a population doctor. So if there's a team of 8 respiratory physicians in a hospital, one of them, even one day a week, thinking, how many people are there with asthma in Somerset? Nobody, when you ask that question, nobody knows. What proportion are you seeing in the specialist service? What's the variation in referral from different family medicine? How many pharmacists are there in Somerset? Because the pharmacists give all the medication. So what do they know about what you're trying to do? So it's starting to see the doctor as a knowledge worker. And what I say to hospital chief executives, pointing at one, is, are you in the real estate business or the knowledge business? You know, if you're in the real estate business, you've got all these buildings to pay for. It's a nightmare, I know. But you employ all these clever people. But the only way their knowledge gets is if I come and park in your hospital. And so starting to think of ways in which the role of the specialist changes. And this is the work we're doing with BMJ, is thinking of a knowledge worker. Healthcare is a knowledge business. The president of Toyota said Toyota is a knowledge business, not a car business, it's a knowledge business. So you've got to think about knowledge and how the knowledge in the heads of the specialists gets to the patients and the pharmacists and the generalists. Now then we come to innovation, and we'll hear about innovation later. And so we're looking at innovation now in a time of zero growth and think of ways in which innovation can be funded, and it will have to be funded by the clinicians. So we've resisted innovation too much because it costs money. But the approach we're going to take now is, if you came along with some terrific innovation for rheumatology, an exercise program or something, and I'd say, instead of saying no, we'd say, that sounds a really good idea. So how are you going to find the resources to get that? You know, because you will know there's lower value things taken. So I called it, about the carrot and the stick, hitting them with the carrot. So getting the clinicians involved in innovation and to increase value. And then finally, we're looking at the whole care pathway. And this was a project we did in London, where with the patients in the room, and there were about 3 or 4 different bureaucracies here, we looked at all the spend. This was on COPD. I made the decision to move the money from triple drug therapy to smoking cessation and rehabilitation. So you're starting to look within the whole pathway. Again, perhaps more complex in an insurance-based system, but with a map on the wall and the number of people, you have to think in different ways about what we're doing. So just to finish, how do we get there? 2 things. Firstly, systems development, and secondly, culture change. So these are the sort of questions that we can't answer. We can't answer them in England. You know, is asthma care better in Liverpool or Manchester? I don't know yet. After 70 years of health service, we don't know if asthma care, I picked quite a simple example. Asthma is quite a simple condition. We spend £1 billion a year and we don't know, is it better in Liverpool or Manchester or Somerset or Devon or London or Birmingham? And then getting down to more local, you see asthma is more local, but for where there's neurosurgery involved, you might have a bigger population size. So we're thinking different sizes of population for different types of problems. And of course, the bureaucracies can't do this. This is complex, non-linear. Bureaucracies are linear. Bureaucracies are very good at doing linear tasks, like the fair and open employment of staff and the uncorrupt management of money. That's what bureaucracies are good at doing. But they're not good at developing integrated services for people with headache or people with asthma or people at the end of life. That requires the development of systems. So this is the usual pattern. It's an archipelago of different, patients swim across from one island to another, or big ferry boats go from there to there. But it's an archipelago, and it will not be solved by bureaucratic reorganization, because bureaucracies are linear and health challenge is non-linear. So what we need is to create population-based systems. And here's on the right-hand side is a systems diagram. Now, for asthma, you probably wouldn't have super specialist care, but and these, you see, the most important type of care is this and this. Self-care and informal care. Then we come to generalist care, then we come to specialist care, and sometimes super specialist care. And we've called this population health care, and it's healthcare focused on populations defined by either a symptom, and symptoms are often much worse managed than conditions. Women with pelvic pain, people who are breathless, headache, backache, huge amounts of resources badly used for symptom. Then there's people with a condition, like asthma or epilepsy, and then there's people with a characteristic, like multiple conditions, or single homeless people, or people in the last year of life. So that's the language of what we call population health care. And then finally, the culture of stewardship. Stewardship, I found a word difficult to translate. Evidence translates, as you know, very badly. Evidence-basiert Medizin. I remember when we were at the conference in the Charité, I saw these young doctors and having a talk in the pathology museum, and they said, there's a problem. I said, what's the problem? The problem's the term evidence-basiert Medizin. Evidence means not requiring proof. It does in English too. You know, it's evident that I'm Scottish to people in English. It's evident. So I said, well, we don't care what you call it. What do you want to call it? And they said, I thought we would call it kritische Medizin. I said, that's fine, call it. And then the young doctor said, no, we will change the German language. So, so evidence is about... Now, value translates, in my view, very well. Value in the singular, sort of economic, and value in the plural in both English and German means principles. Our values in this hospital are openness and transparency. But the word stewardship I find quite difficult to translate. From Dutch people yesterday I learned Renmeisterschaft. Renmeister. So the steward is the person, he's not the owner of the land, but he's employed by the landowner to manage the farms. And the good steward leaves the land in better condition than they find it. So the word stewardship came back into use with the environment. We're the stewards of the planet. You know, we screw it up. It's our children and grandchildren who will suffer, not us. We don't own the planet. We don't own the health service. So we're using, and this is a very good report from the Academy of Medical Royal Colleges, which said that we need stewardship. Wasting resources, it's other patients who suffer. It's not the taxpayer who suffers. It's other patients. Taxpayer doesn't care, you know, if there's, because we're not going to increase the spending. It's this other patient. So when we come back to discuss whether there's a translation of stewardship or how relevant. This is now me starting, you know, if I'm on the road, making an emotional appeal. I'm trying to get the emotions of the clinicians involved. Because it's easy for them to blame the Minister for Health or the insurance companies or whatever, you know, that's what people like to do, or blame the managers. The clinicians like, we ban the word manager, I was saying, because it allows the clinicians to hate the managers. So we use the phrase people who manage. So I say to the clinicians, oh yeah, people who manage, yes, like you. Oh, I'm not a manager. Well, wait a minute, you know, yeah, have you ever ordered an MRI? Yes, I do it every day. Well, you're managing resources. So this stewardship, and this means there's a new language needed, which I've covered some of this today, and new training. And with BMJ, we've developed training, and we'd hope to do this jointly with, if it's of interest to you, with the Ärztekammer here and perhaps in others, because there's a lot to learn from working together. So, the future is increasing need and demand. More of the same is necessary but not sufficient. The new focus is on value for individuals and populations. And it's not about the money, it's about the value for individuals and populations. Just finished, we'll get to maybe 1 minute before coffee. Just turn to your neighbour for another minute and reflect on I've been talking about a tax-based system where we spend less money than you. We should probably spend more money. Just reflect on the relevance, if any, of what I've been saying to healthcare in Germany. Okay, just 1 minute, and then we'll break for coffee. Okay, 10 seconds. Okay. All right, time to stop talking. You must stop talking or you will get coffee. Must stop talking now. There's evidence you'll probably remember more what you said to your neighbour than what I said to you. I mean, it's in these discussions. I just point at you. I don't look for volunteers. What you guys discussed?
We discussed the German translation of stewardship.
Yes. Yeah. Fiduciary. Mm-hmm. What do you guys make of stewardship?
Well, we were wondering about maybe the image of the agriculture.
Mm-hmm.
There's some value to that.
Yeah. So what?
In German term like Landspfleger.
Landspfleger. Yes, carer. Anyone else in stewardship? The sort of official definition, this is from Peter Black, stewardship is to hold something in trust for another, or to hold something in trust for another generation. So it's this idea of holding Landpflege, that's very nice. Anyway, anything better than Gesundheitswesenpflege? Okay. Last hospital chief exec, I've put you. Are you going to move into population business? Are you there already? What would you like to comment?
We were discussing if the population is ready to be involved in self-caring.
Yeah.
It needs a lot of education.
Yeah, in some way we've probably created a dependency that. But our evidence is that the public are up. They're very keen, and at any age we're. And I'm sure there's experiments here with people with tablets and people with dementia. I think they should have a tablet in their home with all the record on it, because that's the only way you'd know who'd been to visit them if we made a recovery. Okay, well, thank you very much for your time, and we'll be here all day and look forward to the further discussions with you. Thank you.